So here's an outline of the different segments of neurology that we'll be covering this afternoon, starting from neuromuscular junction diseases all the way to multiple sclerosis. We'll cover some key points and some clinical pearls. So we'll start with an audience response question. So you have a 33-year-old female who comes in with ptosis of the left eye. On examination, she has dysconjugate gaze that's worse with fatigue. She also has weakness of her proximal arms and legs. On examination, her sensation is normal. Her reflexes are unremarkable. She does not have dysmetria, and she does not have ataxia. So here's a video of her examination. Which is the test most likely to be abnormal in this patient? MRI of the brain, CT chest, CT abdomen, or MRI of the cervical spine? So the correct answer here is CT of the chest. The clinical diagnosis here is myasthenia gravis. So part of the workup for myasthenia gravis is looking for a thymoma. To evaluate for a thymoma, you would want to get a CT of the chest. An MRI of the brain would be helpful in certain cases, but not in this particular clinical presentation. CT abdomen is not indicated at this point, and MRI of the C-spine is also not part of the workup. So what are the key clinical features of myasthenia gravis? You can either have ocular involvement, bulbar involvement, meaning cranial neuropathies, or you can have proximal weakness in the upper extremities or in the lower extremities. And this weakness is oftentimes very fatigable. So the evaluation for myasthenia gravis involves blood work, antibody testing. We're looking for the binding, blocking, and modulating antibodies. If these are negative, then further testing can include antibodies for the MuSK antibodies. In the outpatient world, we can coordinate EMG, nerve conduction studies, where we look for decrement. We talked about the evaluation to rule out thymoma. This can be seen in about 10% of the cases. The treatment for myasthenia gravis involves supportive treatment and also long-term management. The go-to therapy is pyridostigmine. For long-term management, patients can be on steroid or non-steroid sparing agents. These can be oral or can be IV. For acute exacerbations, inpatient treatment may include plasmapheresis or IVIG. Obviously, if there's a thymoma, you would want to refer for a surgical evaluation. The non-steroid sparing agents include immunosuppressant therapies, as listed there, azathioprine and methotrexate or mycophenolate. Here's an example of what you would see on outpatient evaluation with neurodiagnostics. This is a repetitive simulation nerve conduction study, so you would see the decrement pattern there. Myasthenia gravis is part of the neuromuscular disjunction disorders. It's on the presynaptic side. On the other side, there's postsynaptic disorders, such as Lambert-Eaton. Lambert-Eaton is actually seen with paraneoplastic syndromes, mostly associated with small cell lung cancer. The key features of Lambert-Eaton are similar but different from myasthenia gravis. The fatigability is usually not common, and patients actually may get facilitation with exercise. The reflexes on Lambert-Eaton are also hyporeflexic, and there's also more autonomic dysfunction, such as dry mouth, blurred vision, constipation, and impotence. Here, there's involvement of the calcium channel antibody, and there's also increment on the repetitive nerve stimulation test. And to clarify, Lambert-Eaton is actually on the presynaptic side versus the myasthenia gravis being on the postsynaptic side. So here's a case discussion. We have a 25-year-old male who presents with acute dysphagia for the past 2 days. He was found to have abdominal paresis, bilateral ptosis, proximal muscle weakness, and decreased reflexes. On further examination, his sensation and coordination were normal. His pupils were also enlarged and poorly reactive. Looking at his nerve conduction studies, there's pre- and post-exercise increment. So this case here demonstrates a case of botulism. There's different kinds of botulism infection or intoxication. There can be congenital forms, there can be toxic or drug-related or even food-related. In this case, after the EMG, the patient admitted to using drugs, and he used the same needle for 2 days prior to onset. Treatment of botulism includes the botulism antitoxin therapy, and the CDC must be notified. So we have another audience response question here. A 44-year-old female presents with a 2-month history of waking up at night with her whole right hand tingling. She has pain in the wrist, but nowhere else. Her past medical history is notable for hypertension and hypothyroidism. Her medications include antihypertensive medications and thyroid medications. Her neurological examination, she's awake, alert, oriented ×3. She has no bulbar findings. On further evaluation of her extremities, she has decreased sensation over the first through third digits in the right hand. She has normal bulk, and her strength is otherwise unremarkable. She has no dysmetria, and she has no ataxia. What is the next best step in the management for this patient? Night splints, MRI of the cervical spine, steroid taper, steroid injections, or orthopedic hand surgeon referral. So this is a straightforward question. Majority of the audience got the question correct. The diagnosis here is carpal tunnel, or otherwise known as median mononeuropathy of the wrist. Choice B, cervical spine MRI, would be indicated if the patient had longer symptoms, if they have cervical pain, cervicalgia, neck spasms, or chronic history and other localizing findings. Steroid taper would be indicated later on in the management. Steroid injections would be a reasonable option. Orthopedic hand surgeon referral would be considered in severe cases. So in terms of focal neuropathy, we think about the periphery, upper extremities as well as lower extremities. The most common focal neuropathy in the upper extremity is median mononeuropathy of the hands, otherwise known as carpal tunnel. So carpal tunnel is an entrapment syndrome typically caused by overuse. There's sensory involvement in the first through third digits. The symptoms are typically nocturnal. There's different clinical signs that you may find, Phelan's testing or Tinel's testing. In severe cases, there may be associated weakness. The confirmatory diagnostic test is nerve conduction studies. The EMG is helpful to classify if the symptoms are active and chronic, and also grading the severity, mild, moderate, or severe. In mild cases, we recommend supportive treatment with wrist brace, typically at night. In more moderate to severe cases, referral for orthopedic injection of steroids is indicated, and for severe cases where there's ongoing findings in the hands, then orthopedic evaluation for carpal tunnel release is very appropriate. The other focal neuropathy seen in the upper extremity involves the ulnar nerve. This is also known as cubital tunnel syndrome. This involves entrapment of the ulnar nerve across the elbows. The symptoms are typically in the medial aspect of the hand, involving the fourth or fifth digits in the hypothenar aspect. In severe cases, you can see muscle weakness of the interosseous muscles as well as atrophy. Again, EMG is useful to help exclude other alternative diagnoses and also classify the severity and also localize if it's proximal or distal to the elbow. The less common focal neuropathy of the upper extremity involves the radial nerve. This is also known as Saturday night palsy. So the presentation here involves a wrist drop. There's compression of the radial nerve typically across the spiral groove, EMG is also helpful here of the radial motor nerve to evaluate the severity. The treatment here is usually supportive and also evaluating other underlying etiologies. The recovery in these cases are generally excellent. In the lower extremities, there's typically two focal neuropathies that we consider. The femoral neuropathy involves weakness of the knee extensors as well as hip flexion. The patients typically have absent patellar reflexes, and in these cases, we should rule out retroperitoneal hematoma, either from trauma or other etiologies. Another common focal neuropathy of the lower extremity involves the peroneal nerve. The compression here occurs across the fibular head. The presenting symptoms involve foot drop. There's weakness of eversion, but the inversion movement is intact. EMG nerve conduction studies are also helpful in these cases to localize between a plexopathy versus a focal peripheral neuropathy. Treatment and management here involves supportive care, AFOs, low weight patients frequently avoid crossing their legs, and positional changes. In terms of localization with reflexes, the L3-4 reflex involves the L3 and 4 involves absence of the patellar reflex. There's weakness of the knee extensors. L5, there's involvement of dorsiflexion weakness, both eversion and inversion. So the key there is whether there's eversion or inversion weakness. In L5, there's also decreased sensation on the dorsum of the foot. However, in S1 localization, there's absent ankle reflexes, and the decreased sensation is on the bottom of the foot. And there's also involvement of plantar weakness. So the key distinguishing factors are whether there's dorsiflexion weakness or plantar flexion weakness, and where the sensory changes are in the foot. We have another audience response slide. You have a 35-year-old male who presents with back pain radiating down his right leg for the past week and a half. He has no significant past medical history, no bulbar findings on evaluation. His strength is intact. On straight leg testing, there's radiating pain. He gets tingling on the bottom of his foot. His ankle reflex is absent, asymmetric on the right. In this case, what is the most appropriate statement and plan at this point? A, lumbar strain, conservative treatment. B, S1 radiculopathy, conservative treatment. C, L5 radiculopathy, conservative treatment. D, S1 radiculopathy, confirmed with MRI of the lumbar spine. E, L5 radiculopathy, confirmed with MRI of the L spine. So here we have a variety of responses. B and D were the most popular. B is the correct answer. So B, this patient presents with sensory changes on the sole of his foot. So this would be an S1 radiculopathy. The answer choices A through D, or A through C, have conservative treatment. So conservative treatment is important because those are part of the guidelines for management of lower extremity symptoms. And this is guidelines from different societies. As we talked about before, L5 and S1 present with different weakness patterns, weakness of either dorsiflexion or plantar flexion, and also whether it's the dorsum or the sole of the foot. Imaging is certainly indicated and appropriate in certain cases, depending upon the chronicity and also failure with supportive treatments and other localizing symptoms. Related to that, how do we manage back pain? And this is something that's seen in clinic as well as sometimes in the hospital. Different societies have come up with different recommendations. This is based upon the ACP guidelines from 2007 and 2011. Over the first month, they recommend conservative treatment. However, if there are red flags or other first case scenarios, then additional treatment options and evaluation is indicated. If there's known cancer, then you want to proceed with an X-ray. If there's multiple risk factors for cancer, you should also proceed with an X-ray. If there's concern for osteomyelitis, other presenting symptoms with fever, leukocytosis and such, then you should get additional history. If there's history of injection of drug use, TB screening, and such. If there's urinary retention or fecal incontinence, then urgent MRI is indicated. If there's progressive motor weakness, meaning the symptoms are progressive over a short period of time, then additional evaluation with MRI is certainly indicated. So here we have another audience response question. A 25-year-old had a viral upper respiratory prodrome or syndrome over 2 weeks. He now presents with 3 days of progressive weakness accompanied by acute back pain. He has tingling in his feet and absent vibration at the toes. His strength is 4 out of 5 at the shoulders and hips, as well as 3 out of 5 in the hands and dorsiflexions of the feet. He has hyporeflexia. He has bilateral facial weakness and cannot lay flat. This makes him uncomfortable. He also has mild neck strength. Which would be the most appropriate initial test to order in this case? An ABG, lumbar puncture, MRI of the L spine, forced vital capacity, oxygen level, or chest X-ray. So here we have a variety of answer choices responding back, D at 50% and B at 31%. So the diagnosis here is Guillain-Barré syndrome, AIDP, otherwise known. So part of the initial workup for Guillain-Barré is making sure the patient is clinically stable and monitoring for further progression. So the correct answer is a forced vital capacity. The other answers are part of the workup, but is not part of the initial test. ABG would be reasonable if there's respiratory compromise, if they're in the ICU, pending respiratory failure. Lumbar puncture is also indicated. We'll talk about that in the next slide to look for certain patterns of the CSF analysis. An MRI of the L spine would be indicated in atypical causes, but would not be helpful in this case. Oxygen level would be part of the vital signs, but not one of the initial tests for diagnosis in this case. Chest X-ray would be helpful if there's concern for secondary complications. So Guillain-Barré syndrome, otherwise known as GBS or AIDP. Typically, there's an antecedent viral upper respiratory prodrome or syndrome. The culprit may be Campylobacteria. The presentation involves ascending, typically symmetric paralysis involving both the proximal and distal muscles, and also there's hyporeflexia or areflexia. There's typically involvement of respiratory failure and autonomic dysfunction, so the blood pressures may be liable. The patients in the hospital setting typically require ICU support. There's a specific pattern that is seen with the CSF analysis. It's called cytoalbuminological dissociation. That's where you see elevated protein with the normal white blood cell counts. The other presenting symptoms involve back pain, and there may be sensory involvement. The CSF analysis can be negative in a small percent of early presenting cases. So in terms of management and treatment, the American Academy of Neurology came out with practice parameters in 2003. IVIG and plasma exchange have been proven to be equivalent. Steroids have not been proven to be efficacious. In terms of when the patient presents, this also is a factor in determining treatment choices. For ambulatory patients within 2 weeks of symptom onset, or non-ambulatory patients within 4 weeks of symptom onset, Plex may be more efficacious, plasma exchange. For patients requiring an ambulatory aid, IVIG should be started within 2 to 4 weeks of symptom onset. In terms of recovery, the patients may recover between weeks up to months after the diagnoses. IVIG followed by Plex or vice versa, there's no clear data on either one. So the chronic form of GBS or AIDP is known as CIDP, or chronic inflammatory demyelinating polyneuropathy. This form of neuropathy is an autoimmune neuropathy. The symptoms typically involve 8 weeks or longer of progressive symptoms which may be relapsing. The presentation involves proximal and distal muscle weakness, and there's more diffuse pattern rather than a length-dependent pattern. There may be areflexia. On EMG, you see this distinct pattern called demyelination. There's demyelination noted on the peripheral nerves. And there's also conduction block. Similar to AIDP, you may have an elevated protein. The treatment for CIDP relies on long-term immunomodulation, such as IVIG, steroids, plasmapheresis, or steroid-sparing agents such as chemotherapy agents. In terms of evaluating generalized weakness, we're looking to localize where the weakness could be from. That relies on the pattern of the weakness, whether it's proximal, whether it's distal. You want to determine if there's bulbar involvement. You also want to determine if there's fatigability. If there's fatigability, then motor diseases such as myasthenia gravis may be considered. The dermatomal patterns may also be helpful in the localization. So the lower motor neuron symptoms suggest nerve root or nerve problems in the periphery. Bulbar findings suggest neuromuscular junction disorders. Proximal greater than distal suggest muscle disorders. So in terms of your metabolic evaluation for neuropathy, what screening labs would we want to obtain in the outpatient setting? There's been studies that have shown that oral glucose tolerance testing is more sensitive than hemoglobin A1C. You would want to check for B12. B12 deficiency is a common treatable cause of neuropathy. Thyroid dysfunction can be seen with other presenting symptoms such as carpal tunnel neuropathy or even myopathy. SPEP or serum immunofixation is useful. You want to look for MGUS and other hematological disorders. Some cases may be idiopathic, other cases may be toxic, depending upon the history. You would want to check for HIV status, their history suggestive of alcohol intoxication, checking B1. If the patient has wrist drop in particular that's not localizing to the radial nerve, then you want to check for lead poisoning. So in terms of inflammatory myopathies, these patients present with subacute weakness and have elevated CK. Other lectures have discussed dermatomyositis and polymyositis and how these may be associated with underlying malignancy. Dermatomyositis presents with rash. The pathology presents with perifascicular atrophy. Polymyositis involves inflammation invading the non-necrotic muscle fibers. There's also another entity called inclusion body myositis. The presenting features here may involve finger flexor weakness as well as knee extensor weakness. Those are two key hallmarks of IBM. The pathology with IBM includes vacuoles and amyloid. The treatment option depends obviously on the underlying diagnoses, but may involve steroids, IVIG, methotrexate, or other chemotherapy agents. Dermatomyositis, like we talked about, involves perifascicular atrophy. It may also have other cardinal clinical features as outlined here. This example shows how on clinical examination, if you test the reflexes, you can determine if there's quick or slow release. That may be helpful to localize as well. So we have an audience response question. You have a 67-year-old who presents with a 5-month history of progressive weakness. It began with a right foot drop, but has been progressively slow to involve other limbs. He has atrophy of associated muscles and some fasciculations. His reflexes are hyperreflexic throughout, and he has an upgoing toe. He has normal sensation. There's no ataxia, and there's no dysmetria. What is the best medication for this patient at this time? Prednisone, azathioprine, pyridostigmine, creatine, or riluzole? So mixed responses on this one. So this patient presented with both upper and lower motor neuron features, as well as weakness. The symptoms were progressive. So the key to the diagnosis here is the presenting symptoms of both upper and lower motor neuron involvement. So the diagnosis is actually motor neuron disease, ALS. So in this case, riluzole would be the recommended treatment of choice. Prednisone does not work well long-term with ALS or other motor neuron diseases. Azathioprine, not proven to be efficacious in ALS. Pyridostigmine would be for myasthenia gravis. Creatine would be for other conditions. So we have another audience response question. You have a 47-year-old male who presents with vertigo. He's had symptoms for over a week. He describes multiple bouts of intense room spinning sensation multiple times throughout the day. The attacks last 15 seconds at a time and are generally triggered by standing or looking to the left. His past medical history is notable for lupus. His medications are listed there. His neurological examination is without dysmetria or ataxia. Which treatment is the most likely to be effective in this patient? Salt restriction, prednisone, cannula repositioning, aspirin. So 87% was C. That is the correct answer. So we're going to talk briefly about a vertigo at this point. So in terms of vertigo, we want to distinguish if it's a peripheral or a central cause. So the red flags or the warning signs that are suggestive for a central cause typically involves nystagmus that may be in all directions or vertical. The deficits typically involve some other focal deficits that may localize to the cerebellum. There may be cranial neuropathies or other cranial nerve abnormalities. The central etiologies involve a lesion in the brainstem or the cerebellum. The peripheral etiologies typically are benign. So the most common is BPPV, benign paroxysmal positional vertigo. The test of choice here is the Dix-Hallpike maneuver, which can be done with different positioning. The treatment is the Epley maneuver. Typically, patients are referred for vestibular rehab. The symptoms are generally brief and they're positional. Vertigo, the patients typically describe as a room spinning sensation. Sometimes patients describe symptoms of dizziness. It's very important to ask them what they mean by that, whether it's actually room spinning sensation or that they feel like they're on the boat. If the symptoms are acute and they have significant vertigo with nausea and vomiting, it's more likely labyrinthitis or neuronitis. This is an acute inflammation of the labyrinth pathway in the ear. If the patient has hearing loss, tinnitus, or an aura of fullness, then the diagnosis of Meniere's disease is more likely. The more indolent or more aggressive forms could be acoustic neuroma. Typically, the patients have unsteadiness, and they have this tilt or veering to one side, and they have hearing loss. Part of the workup for acoustic neuroma would be imaging. We have another audience response question. You have a 73-year-old female who presents for evaluation of tremor. This tremor has been worse over the past 6 months. On examination, you notice that the patient has mild increased tone in the extremities and decreased arm swing with gait evaluation. There's no clear family history of tremors. The rest of the patient's examination is non-focal. The patient states that she's had tremor of the head, but you also notice a tremor in the chins. Her past medical history is notable for vascular risk factors, hypertension, diabetes, hyperlipidemia, osteoarthritis, and CAD or myocardial infarction. Her family history is notable for cancer and heart disease. There's no clear family history of tremor. The characteristics of the tremor are outlined in the next video, as we see here. Which would be the most effective medication for this patient? Propranolol, primidone, clonazepam, carbidopa, levodopa. %. So this one is fairly straightforward. So the patient here has Parkinson's disease, typically idiopathic Parkinson's disease. Propranolol would be a treatment option for a central tremor. Primidone is also used for a central tremor. Clonazepam can be used for generalized tremor. So what are the key cardinal features of Parkinson's disease? There's a clinical triad involving bradykinesia, which is slowness of movement, postural instability, and rigidity, as well as resting tremor. The tremor the patient had in the video was resting, often called a pill-rolling tremor. Parkinson's disease responds very well to dopaminergic therapy, such as carbidopa, levodopa, or dopamine agonist. It's key to distinguish Parkinson's from essential tremor. So the tremor of Parkinson's disease is typically a tremor at rest. The tremor with essential tremor is a postural tremor, more notable with action. There's typically a family history with essential tremor. It's also known as hereditary essential tremor. The history of alcohol use may be helpful as well. The duration of the tremor symptoms can also be helpful, whether the patient has tremors over many years as well. There are other minor features of Parkinson's disease that may be useful in the diagnosis: constipation, micrographia, and autonomic dysfunction. There's also drug-induced Parkinsonism. So if the patients are on neuroleptics or other medications such as metoclopramide, then you can also think about atypical etiologies. There's also vascular Parkinsonism, which is seen in patients post-stroke. So in terms of Parkinson's symptoms that do not respond well to dopaminergic therapy, one also has to think about Parkinson's plus syndromes. So there's 3 common Parkinson's plus syndromes that may be encountered. There's progressive supranuclear palsy, which is PSP. These patients present with vertical gaze palsy. They have early falls. So if you have a patient that is slow, that has a tremor, and they fall, and they have upward inability to look, then PSP should be considered. Another condition called multiple system atrophy, or MSA, involves significant autonomic dysfunction. So the patients may present with syncope or other autonomic disarray. These patients typically have abnormalities in the cerebellum as well as the brainstem. These patients are also ataxic. A rare condition called cortical basal degeneration can be seen. These patients typically present with alien hand phenomenon. They're not aware of their hands. They also have this other finding where they're not aware of their hands. They have cortical sensory loss. If the patients present with urinary incontinence, memory loss, and ataxia, then the diagnosis of NPH should be considered. Normal pressure hydrocephalus. In the emergency room setting or other rare conditions, there are 2 conditions that need to be also considered: NMS and serotonin syndrome. NMS has a hallmark pattern of rigidity. The triggers may be a neuroleptic agent or withdrawal from Parkinson's medications. The treatment is typically supportive, finding out what the offending agent is, and other treatment options may be indicated. Serotonin syndrome typically presents with hyperreflexia, tremor, and clonus. They do not have rigidity. The triggers may be SSRIs, MAOIs, TCAs, SNRIs, or other medications as noted. Again, the treatment is geared towards discontinuing the offending agent, supportive care, monitoring respiratory status, etc. Restless leg syndrome can be also seen. Restless leg symptoms involve the urge to move, typically at night. It's important for restless leg patients to have certain labs checked because we know that iron deficiency may be seen with RLS. So you would want to check iron, ferritin, and TIBC. Treatment for restless leg symptoms involve dopamine agonist. So we have an audience response question. A 26-year-old male presents to the emergency room with a severe, ongoing retroorbital headache. He describes the headache as stabbing, and it's been going on for 40 minutes. He awoke from sleep at 2 a.m. for the past 5 days with similar headaches, lasting about an hour. He had similar episodes of headaches for about 3 weeks last year. His past medical history and family history are unremarkable. On neurological evaluation, he has no focal findings. He has no papilledema with fundoscopic examination, and he has no nuchal rigidity. Which of the following is the most appropriate step in management for this patient? 100% high-flow oxygen through a mask, propranolol, prednisone taper, verapamil, lumbar puncture, or a trial of indomethacin. Good, 78% for A. So over the next few slides, we're going to go over common headache types, both primary and secondary. So your primary headaches are listed below. These are the key features that help distinguish these different headache types. You can have tension headaches, where patients present with a dull, band-like appearing headache. The location is typically frontal and bilateral. The timing is indolent. Migraine headaches can be episodic or chronic, and they can be with or without aura. Typically, these patients present with pounding, throbbing pain. They may have associated nausea, and they may have associated phonophobia or photophobia. The location is usually unilateral, but can be bilateral. The timing can be brief to several days. Cluster headaches occur in clusters. Typically seen in males, they have autonomic features, and they have this stabbing type pain. The location is retroorbital. They may have crying or tearing. The duration can be brief, up to a few hours. Then they may wake the patients from sleep. Trigeminal neuralgia is also considered a primary headache syndrome. The pain can be excruciating. It can be localized to one side, involving different parts of the trigeminal nerve. Typically, it's the middle to the lower part, V2 or V3. The symptoms are typically brief. In terms of secondary headaches, where there's a cause underlying to the headache, there can be idiopathic intracranial hypertension. The typical presentation involves a young, obese female. The patients may have vision loss. They may complain of diplopia. They may have papilledema. There are other risk factors that can be seen with the use of tetracyclines, other underlying conditions as listed there. The treatment involves acetazolamide, furosemide, or shunt placement. Intracranial hypotension is postural. There's a positional component. You can have this after a lumbar puncture, so you can get a post-procedural headache. The headache is typically diffuse. Treatment includes IV fluids, IV caffeine, and blood patch. So if you refer a patient for lumbar puncture and they have headaches immediately after, and it's positional in nature, then it's most likely an intracranial hypotension-related headache. Less common causes, but can be seen in certain populations, include cerebral venous thrombosis. So these patients may be on oral contraceptives, may be females. Here, the headaches involve increased intracranial pressures. There's usually altered level of consciousness. The patients may have focal deficits, unilateral or localizing findings. Typically, there's visual changes involved. The patients may have seizures. Cerebral venous thrombosis can occur postpartum or peripartum or even in hypercoagulable states. The treatment involves anticoagulation. Carotid dissection is also another syndrome that can present with headaches. The patients typically present with severe headaches. They may have cervical pain radiating to the eyes. The dissection may be traumatic or non-traumatic. Typically can be seen after chiropractic treatment or maneuvers. The patients may present with Horner syndrome, or they may present with other localizing findings. The diagnostic workup would involve a CT angiogram or conventional angiogram. The treatment here would be antiplatelet therapy or anticoagulation. The data goes back and forth between efficacy between those two. In certain age populations, you need to think about giant cell or temporal arteritis. Typically, patients are older than 55, in their 60s or 70s. These patients present with vision loss. On laboratory studies, they have elevated ESR. They may also have jaw claudication. On clinical evaluation, they may have temporal tenderness. They may also have PMR. The evaluation involves temporal artery biopsy. I'm sure the other lecturers may have mentioned it, but there's data about whether it's unilateral or bilateral temporal artery biopsies, but the sooner the biopsies are done, the better. Treatment is very important to start steroids early on. So we're going to shift gears and talk about some other cerebrovascular conditions, such as subarachnoid hemorrhage. Typically, the patients present at various ages. They can be younger than 40 years. They typically present with some type of mild headache. Here listed are conditions that are not too concerning for subarachnoid hemorrhage. The workup involves CT of the head, CT angiogram, and or lumbar puncture. If you do a lumbar puncture, you're looking for xanthochromia. If there's subarachnoid hemorrhage, certainly you will want to involve neurosurgical consultation. You want to look for underlying etiologies or causes, such as a aneurysm, as well as other tumors. The concern with subarachnoid hemorrhage is treatment and management of the vasospasms, where the blood vessels have a chance to continue to have vasospasms throughout the first 4 to 14 days. There may also be associated hyponatremia, so these patients require ICU evaluation. We have an audience response question here. A 34-year-old male comes to the emergency room for evaluation of severe pain radiating from the flank to the groin with hematuria. He has a history of epilepsy. He has been seizure-free for over 1 year. On neurological evaluation, no clear deficits are noted. Which seizure medication is this patient most likely taking? Levetiracetam, pregabalin, lamotrigine, gabapentin, or topiramate? %73% for E, which is the correct answer. So this patient most likely had a kidney stone. The most likely anti-epileptic drug to cause kidney stones in this case is topiramate. So here's a summary slide of key associations for anti-epileptic medications. So we'll go through this slide. So phenytoin is typically associated with gingival hyperplasia. There's also chronic ataxia that may be seen, and also osteoporosis. You also have to monitor drug levels. Carbamazepine and oxcarbazepine are associated with hyponatremia. The benefits are access and cost. Topiramate, we just talked about the risk for kidney stones. Topiramate is also used in certain cases for its benefit of weight loss. The other side effects of topiramate to keep in mind are paresthesias. Typically, patients present with perioral paresthesias, or they may report changes in taste with sodas. There may also be cognitive difficulties. In particular, patients report word-finding difficulty. Levetiracetam typically has associated irritability and agitation. This can be seen at higher doses and also in the elderly population. Valproic acid has been around for a long time. The known side effects are pregnancy risk, it's teratogenic risk factors, weight gain can be seen, hair thinning can be seen, tremors can also be seen with long-term use of valproic acid. On rare cases, thrombocytopenia or elevated ammonia levels can be seen. Lamotrigine has to be started with caution because a life-threatening rash can be seen, Stephen-Johnson syndrome. So in terms of the evaluation for seizures, seizures are classified as either localization related or generalized, complex or simple. For the evaluation of new onset seizures, obviously you want to get a history and physical, find out when the seizure onset was, what their semiology or how they describe their seizures are. The evaluation includes basic blood work, looking for treatable causes of seizures, such as BMP, liver function testing, toxicology screen. Nowadays, there's new concerns about autoimmune encephalitis, such as NMDA or other HSV-presenting symptoms. Imaging is indicated to evaluate for underlying structural etiologies that may be treatable. If it's localization-related epilepsy, you may see a lesion in the mesial temporal lobes. EEG, whether that's a 30-minute EEG or an ambulatory EEG, is also indicated. It's important to note that a negative ambulatory 30-minute EEG does not exclude the diagnosis of epilepsy. Epilepsy is recurrent seizures. Increased risk of recurrent seizures after the first seizure, if unprovoked, then you need to do further evaluation. If the EEG is abnormal, if there's prior neurological injury, such as concussion, repeated head trauma, if there's family history of seizures, or if there's an abnormal MRI. The risk of recurrence after your second seizure is greater than 60% and 35% after a single seizure. In terms of management of seizures, we focus on the acute treatment and also the chronic treatment. Chronic treatment involves use of IV benzodiazepines. You can either load with phenytoin or phosphophenytoin if there's concern for status epilepticus. It's important to note that phosphophenytoin causes less infusion site necrosis and cardiac disturbances than its sister phenytoin. There's limited data on use of other anti-epileptic medications, but clinically they may be indicated. If there's continued concern for status epilepticus, which is recurrent seizures within 30 minutes or prolonged seizures, then patients may need to be intubated and monitored for further neurological compromise. Patients may require barbiturates or propofol. In terms of management for chronic seizures, you would likely treat seizures if patients have had 2 or more unprovoked seizures. Certainly, if they have an underlying structural etiology, so it's a secondary seizures, then they may also be on treatment. If the EEG is abnormal or there's a focal lesion on the MRI, then they may also require treatment. Generally, patients must be seizure-free for greater than 6 months to consider driving. This is state-dependent. Each of the states have different rules and regulations, but it's very important to discuss with patients what the rules and regulations by that state's DMV is. In the female population of childbearing age, anti-epileptic medications can be difficult to monitor, and you have to proceed very cautiously. There are certain medications that are tetraterogenic that you have to consider. You have to consider if the patients are on oral contraceptive medications. You also have to consider polypharmacy, whether those medications will increase or decrease the anti-seizure medication levels, or vice versa. The anti-seizure medication levels can also increase or decrease other medications. In particular, this is common with the older medications such as valproic acid or even carbamazepine or oxcarbazepine. The most common high-risk drug in terms of pregnancy risk is valproic acid, followed by phenobarbital, Topamax, carbamazepine, and phenytoin. Levetiracetam has a low risk. There's a registry with the CDC that can be helpful in terms of coordinating additional information. In terms of management during pregnancy, it depends upon the patient's seizure frequency as well as seizure risk. Typically, we want to go for monotherapy if possible. When patients present with seizures that are atypical or have negative workup, then a diagnosis of exclusion is non-epileptic seizures. We no longer want to call these pseudo-seizures. The term is psychogenic non-epileptic seizures, or PENS. These seizures are not due to abnormal brain activity, but are psychogenic or stress-related. Again, this is a diagnosis of exclusion and involves most likely a negative EEG as well as typical semiology. So the suggestive features when you see a patient that you think may have non-epileptic spells involved a forced eye closure during the episode. They may have pelvic thrusting. They may have bilateral shaking, but they're aware, and they may have lack of a post-ictal state. The confirmatory diagnosis would be an epilepsy monitoring unit evaluation or an EMU evaluation where the event is captured without notable EEG changes. It's also important to note that there may be a mixed picture. In about 20% of the patients with non-epileptic spells, they may also have underlying epilepsy. At that point, you should refer to a specialist. In terms of evaluating for seizures, you may also see patients that may have syncope. Syncope can present with seizures or vice versa, so it's very important to distinguish the two. Seizures may have a preceding symptom, such as an aura. They may not have an aura. The seizures typically have some type of ictal phase, ictal meaning seizure itself, where there's tonic-clonic posturing, or just tonic or atonic, meaning they're stiff or they're rigid, or they may have a generalized convulsion. The patients may have urinary incontinence or fecal incontinence. They may also have tongue biting. The duration is usually 1 to 2 minutes. It depends if you ask the patients or their caregivers. 2 minutes may seem very long to some patients. Typically, these patients with seizures also have a post-ictal period where they're altered and they're not responsive. In terms of syncope, the presentation is slightly different. The patients may present with feelings of lightheadedness. They may have pallor. They may have nausea, vomiting. They may have palpitations. They may have chest pain, or they may have no preceding symptoms. The ictal or the phase of the syncope itself is typically brief. It may be positional in nature, and there's typically not a post-event episode. There's no post-syncopal confusion. So those are key distinguishing features for the two. We're going to shift gears and talk about stroke. Stroke can be considered ischemic stroke or hemorrhagic stroke under the umbrella of cerebral vascular disease. So in terms of management for acute stroke, you want to make sure the patients are stable, checking their ABCs, doing a history and physical. In particular, somebody should document the NIHS stroke scale. That's typically done by nursing staff as well as trained medical professionals in the hospital. Initially, you want to monitor blood pressure. You want to make sure that there's no major changes in fluctuations in blood pressures. You do not want to drop the blood pressures too fast because of cerebral hypoperfusion. The next few slides will also talk about evaluation for acute thrombolytic therapy. The initial workup should involve a CT of the head with the goal of ruling out a hemorrhagic stroke. You want to check additional laboratory studies, including hypercoagulable panels, if indicated, basic INR, CBC, and glucose. So in terms of systemic thrombolytics for IV TPA, the guidelines were just modified this past year. You have the NIHSS stroke score, which is a standardized stroke scale to evaluate for the patient's deficits and to help categorize outcomes. TPA or IV TPA is now indicated up to 4.5 to 6 hours. Some of the guidelines will be changing, but at this point we want to stick to 4.5 hours for the purpose of this test most likely. There's inclusion and exclusion criteria for IV TPA. It involves duration of symptoms, symptom onset, other co-founding variables, the patient's blood sugars, the patient's coagulable state, and such. And also you want to make sure the patient does not have exclusionary criteria. I'm not going to go into the details because it's unlikely they'll ask you about the details for the algorithm, but be aware of them. In terms of endovascular therapy, so if the patient has an ischemic stroke and there's determined to be a blood clot, meaning there's an occlusion somewhere, then the patients may be eligible for endovascular therapy. This is with or without IV TPA. The patients need to have a ischemic stroke that's not hemorrhagic. The timeline for evaluation of endovascular therapy has now been expanded. Patients may be eligible for clot removal up to 24 hours. And that's new data. In terms of evaluation, there's a concept of aspect score. That's a radiographic evaluation looking at how much of the underlying brain tissue has been evolved. In terms of managing acute stroke after the acute phase, preventing strokes, so it'd be secondary modification. We're talking about anti-thrombotic agents, either antiplatelet agents or anticoagulation. So antiplatelet agents may involve aspirin or dual therapy, aspirin plus diapridamol or Plavix. So there can be a combination of aspirin, Plavix, each independently, aspirin plus Plavix, or a combination of the above. The data on this is variable, but typically if the patients are not on any therapy with their first stroke, with moderate risk factors, an aspirin may be appropriate. But if they failed treatment therapy, meaning they had a stroke on aspirin, then one should consider a stronger agent such as Plavix. If they have notable vascular risk factors, then dual therapy with aspirin plus Plavix may be considered. In terms of anticoagulation, anticoagulation is not indicated for acute strokes because there's risk of hemorrhagic transformation. But if there's underlying atrial fibrillation, meaning a cardioembolic etiology, then anticoagulation would be indicated at some point after the acute phase. Certainly if the patients have a notable cardiac disease, such as a STEMI or LV thrombus, with poor cardiac function, then patients may be a candidate for anticoagulation. If the patient has a DVT with a PFO, then they would be a candidate for anticoagulation. Part of the workup for stroke also involves an echocardiogram looking specifically for the PFO. If the patient has a prosthetic or rheumatic valve, if the patient has a sinus venous thrombosis, then anticoagulation may be considered. The data on dissection is questionable for anticoagulation versus antiplatelet therapy, as we discussed before. And as we noted, there's no clear indication for anticoagulation following an embolic stroke, particularly from endocarditis. So here we're talking about also blood pressure goals for ischemic stroke management. You would want to make sure that the blood pressures are gradually normalized. Part of the workup also involves looking at the patient's vasculature, extracranial vessels, including the carotids. So that can be done by either a carotid ultrasound or a CT angiogram. If the patient has notable symptomatic carotid stenosis, we're talking about NASIC criteria, then the patient may be candidates for intervention. Carotid endarterectomy or carotid stents are indicated for situations where there's greater than 70%, and these should be done within 2 weeks of the acute stroke, and their surgical risk should be less than 6%. Additionally, we need to look for the patient's other risk factors, checking for hyperlipidemia, monitoring diabetes control. You want the LDL less than 70, and also hemoglobin A1C within range less than 6. Those numbers for the LDL goals are a bit lower than your traditional patients because they are considered high risk. We're going to shift gears and talk about hemorrhagic strokes at this point. Again, we want to monitor for stability, ABCs, and if they're on any anticoagulation, you want to reverse the anticoagulation. Typically, these patients, you want to keep the head of bed above 30 degrees. It's been shown that if you optimize their blood sugar levels, the outcomes are better. If there's any seizures, you would want to treat those. If the size of the intracerebral hemorrhage is large, then the patients may be on empiric seizure medications. And in certain cases, you would want to also monitor for elevated ICPs or pending hydrocephalus. The key for a hemorrhagic stroke is blood pressure management, particularly if it's not related to a ruptured blood vessel. You would want to treat systolic blood pressures greater than 160 or CPPs between 61 and 80. In certain cases, surgery may be indicated for intracerebral hemorrhages, particularly patients that are young, patients that have a cerebellar hemorrhage greater than 3 centimeters, or if there's a pending deterioration. If the bleed is supratentorial, meaning it's in the cortical regions, then craniotomy may be indicated for certain types of bleeds. And the candidates that are best for this are young candidates and also patients that have a medium GCS score. So in terms of localization, back to anatomy for a second, it depends on where the stroke is, whether, and this is regardless if it's an ischemic or hemorrhagic stroke. If it's a dominant MCA stroke, then you would see clinical features of the contralateral face and arm greater than leg weakness. Patients may also have aphasia. If it's the non-dominant MCA, you're going to have a neglect rather than aphasia. And the dominance is typically which hand they use dominantly. If the patient has an ACA stroke, the pattern typically involves a leg greater than face, arm. So leg is more notable. If the patients have a subcortical stroke, which we call lacunar infarcts involving the internal capsule, then you're going to have an equal pattern of weakness or presenting symptoms involving the face, arm, and leg. It's also important to note you have to distinguish whether the facial weakness is a central etiology or a peripheral etiology, whether it involves the upper and lower face. If the patient has a stroke in the thalamus, the patients typically present with sensory changes. So you can have a stroke with just sensory changes without motor deficits. Strokes in the brainstem are less common, but typically we have crossed findings where you have bulbar symptoms or cranial nerve deficits on one side, and then you have motor or sensory deficits on the other side. So if you have cross findings, then it's most likely in the brainstem. Cerebellar strokes typically present with ipsilateral dysmetria. As we noted before, intracerebral hemorrhages can also be in the cerebellum. So this is the last audience response question. A 59-year-old male presents with fever and sepsis. His blood cultures were positive for staph. On day 2 of his hospitalization, he developed right-sided weakness and aphasia. He was found to have an acute left MCA stroke. His echocardiogram revealed a valvular vegetation consistent with endocarditis, providing a mechanism for embolic stroke. What is the best course of treatment? Antibiotics and clopidogrel, antibiotics and heparin, antibiotics only, high-dose steroids and antibiotics, high-dose steroids and heparin. %, for antibiotics only. So C is the correct answer. This patient had a stroke secondary to endocarditis. As we discussed before, anticoagulation is not indicated in this case. You would want to treat the underlying culprit with antibiotics. So we're going to shift gears and talk about dementia. Dementia involves memory loss as well as some difficulty with some other domain involving activities of daily living. It's a progressive neurocognitive disorder that interferes with activities of daily living and functioning. So it's not just memory loss. The evaluation typically involves history and physical, as well as some type of central nervous system imaging. Typically, you want to proceed with an MRI of the brain with patients that come in for evaluation of dementia. In certain cases, you may also consider advanced imaging with PET or a nuke med scan. One of the key concepts here is to evaluate for treatable or reversible causes of dementia, because several etiologies are preventable or treatable. B12 deficiency can present with other symptoms such as neuropathy, paresthesias, but can also cause memory loss. Thyroid dysfunction, uncontrolled or untreated thyroid disorders can present with memory loss. In certain populations, syphilis can cause memory loss. Neurosyphilis can be undetected. Depending upon the population, alcohol-related dementias can be seen. In HIV patients, there are also HIV-related dementia due to the underlying HIV itself or treatments. Confounding factors that should be noted are history of a mood disorder or depression. Typically, these patients have a memory loss pattern that's slightly different. They have difficulty with attention and concentration, as well as forgetfulness. The memory loss with Alzheimer's dementia typically involves short-term memory loss rather than long-term memory loss. So the chronicity is also important to elicit. So in terms of Alzheimer's dementia, the patients have a neurocognitive compromise with memory loss, typically a short-term memory loss, intermediate memory loss, and possibly long-term memory loss. But the patients also have visual spatial dysfunction. They have executive dysfunction, and they also have language problems, as well as personality changes. So it's more than just memory loss. The pathology for Alzheimer's disease involves amyloid and tau deposition in the brain. The treatment involves getting the history, educating the patients and family. There's two classes of medications that have been proven to delay the progression to a nursing home-bound state. These involve acetylcholinesterase inhibitors as well as memantine. The acetylcholinesterase inhibitors are indicated for mild to moderate disease. The memantine is indicated for moderate to severe cases. There are now treatment options that involve one pill that has both of those together. The side effects for the acetylcholinesterase inhibitors can be a headache as well as GI symptoms. There's also this concept of mild cognitive impairment, or MCI. MCI nowadays can be considered a pre-dementia form where the patients may or may not progress to early Alzheimer's. The evaluation to distinguish MCI versus early, moderate, or severe dementia involves some type of memory screening. You can either use SLUMS or MoCA or the MMSE. So the standard evaluation for dementia and Alzheimer's involves imaging, MRI of the brain. Typically, patients have some type of finding, whether that's atrophy that may be bilateral, involving the frontal or temporal parietal lobes. The patients also need to have CBC. They need to have baseline chemistries, other blood work to include a B12 and thyroid dysfunction. And then it's also important to evaluate for confounding factors such as a depression screening. Case by case, other patients should have further evaluation. If you think neurosyphilis is high, then you should check RPR or proceed with a lumbar puncture. If the diagnosis is still not clear, then advanced imaging with a PET scan may be indicated. In other cases, there's a strong family history, then genetic testing, looking for the ApoE allele would be also pertinent. But at that point, though, a discussion with a consultant is probably more relevant. EEG would be considered if you think there's a possibility of underlying seizures. Lumbar puncture to evaluate for atypical etiologies if the patient presents with a progressive, rapid onset of dementia, to look for other causes such as CJD. Related to CJD, there's other kinds of dementia other than just Alzheimer's type dementia. If patients have had cerebral vascular disease or recurrent strokes, the patient may have vascular dementia or multi-infarct dementia. These patients typically have a stepwise decline in their neurocognitive status. The treatment may be variable but is geared towards preventing further strokes. The treatments for Alzheimer's, including the acetylcholinesterase inhibitors as well as memantine, are not clinically clear yet. There's normal pressure hydrocephalus, or NPH. We talked about it earlier. There's a triad of urinary incontinence, some gait instability, as well as dementia. These patients need to be evaluated by a neurosurgeon for possible shunting, if that's the case. The diagnosis of NPH is a diagnosis of exclusion and may be difficult clinically based upon presenting symptoms. If the patient has a Lewy body dementia, the patient may have preceding symptoms of Parkinsonism. The pathology for Lewy body dementia is different from Alzheimer's dementia. Here, the patients typically present with visual hallucinations. They also may present with Parkinson's features, and they may also have neuroleptic sensitivity, and they have variable cognitive levels. If the patients have frontal temporal dementia, typically they have executive dysfunction. In particular, they may have personality changes at onset. They can also have sleep disturbance, and they typically present at a younger age, in their 60s. The Alzheimer's dementia patients typically present in their early to mid-70s. CJD is rare, but can also present with progressive, rapid neurocognitive compromise. These patients typically have startle myoclonus. There's a classic pattern on the EEG where you see sharp waves on the EEG. The MRI, you see changes that involve cortical riveting, and the lumbar puncture may be notable for 14-3-3 protein elevation. CJD would be needed to, you would need to report CJD to the CDC, and the lab is sent out to a national center. So medications for Alzheimer's or dementia, as we talked about earlier, the acetylcholinesterase inhibitors, they're indicated for mild to moderate. The side effects include GI symptoms, upset stomach, bradycardia can be seen, and heart block can be seen. Patients also report headaches. There's no effect on progression. That's why its trials indicated that it's delayed to a nursing home bound state. The NMDA receptor antagonists, or memantine, are indicated for moderate to severe. They can be monotherapy or adjunct therapy. In rare cases, you can get dizziness with these medications. The medications are listed below there for your review. So there's one more audience response question. A 25-year-old female with multiple sclerosis developed worsening numbness in her legs over one day. She has had a numbness in her legs chronically prior to transverse myelitis. She has no weakness, incoordination, or visual changes. She has no other localizing symptoms on examination. Her vitals are notable for a temperature of 100.1. Her WBC is 11.5, and she was found to have a urinary tract infection on a urine analysis. Which of the following is the most likely to improve with this patient, or improve this patient? Antibiotics, IV pulse steroids, gabapentin, or pregabalin? So A, 69%. Antibiotics is the correct answer. This patient has a urinary tract infection, even though she does have a history of multiple sclerosis, so you would want to treat the underlying cause of the symptoms at first. So multiple sclerosis. There are several forms of multiple sclerosis: relapsing, remitting, primary progressive, secondary progressive, etc. Typically, the patients are females. They're in the age range of 20 to 40s. There's been theories that vitamin D deficiency is linked with multiple sclerosis. There's also some data that may be related to ethnicity, but that hasn't been proven. The diagnosis of multiple sclerosis involves a history physical, as well as the patient's history of clinical deficits, as well as imaging. You must have clinical or clinical plus radiographic evidence of a space-bearing lesion that's different in time. The criteria for this is called the McDonald's criteria. The general principle is one episode of clinical symptoms does not automatically carry the diagnosis of multiple sclerosis. The patient needs to have one or more, either a clinical or radiographic finding that's separate in time. The clinical features may involve fatigue, focal weakness, or even generalized weakness, spasticity, bladder dysfunction. Multiple sclerosis can also present with bulbar or cranial neuropathies. The patients may present with optic neuritis or diplopia. They may also present with sensory findings involving a paresthesia or dysesthesia or even pain. Some patients may present with gait instability or ataxia. The radiographic findings are most commonly seen on MRI imaging. MRI can be obtained with and without contrast. The with contrast portion is useful for evaluation of enhancing lesions. Those lesions would be active. MRI duration interval scanning depends upon the patient's clinical course, as well as disease classification. Supportive evaluation includes lumbar CSF studies. You may see elevated IgG index, oligoconal bands, or myelin basic protein. Additional testing that may be seen in an academic center may involve prolonged evoked potentials. The prolonged evoked potentials may be of the VEPs, which are actually quite sensitive. Here we're seeing a evaluation of a patient with ocular findings that may be suggestive of MS. So in terms of multiple sclerosis management, we focus on the acute treatment and long-term management. So for acute exacerbations where the patients have an active lesion on imaging, or they have a clinical finding suggestive of active changes without a source of infection, then IV high-dose steroids would be indicated. Obviously, you want to make sure that you look for underlying triggers, such as a urinary tract infection or an upper respiratory syndrome. For long-term management, the patients nowadays should be on some type of immunomodulatory therapy or disease-modifying agent. There are several that are now available on the market. The older agents were typically injectables. More recently, there's been oral options, and there's also been IV infusions. Some of these medications have a high risk for infections. So the older medications, such as interferons, involve possible flu-like symptoms. They may be associated with depression, leukopenia, anemia, or injection site reactions. The other injectable that's common is galantamine. The side effect profile is generally well tolerated, but you may have injection site reactions. There's a risk for PML in the newer agents. PML is an irreversible, quite severe brain disease that is not treatable. That is a big concern for a lot of the newer agents. So you need to screen patients for their JC virus status. Natalizumab is a IV infusion treatment that is highly effective, that's used in severe cases, but the risk for PML is quite high. The two oral agents listed there, you need to monitor for lymphocyte counts. Fingolimide, you need to monitor for early bradycardia with administration, macular edema, and risk for a herpes zoster infection. And then the other agent that's oral, you need to monitor for liver dysfunction. In the realm of neuroimmunology, there's also a condition called neuromyelitis optica, or de Vick's disease, otherwise known as NMO. NMO is characterized by longitudinally extensive myelitis. So this involves several segments in the spinal cord, as well as ocular involvement with bilateral optic neuritis. So it involves the optic nerves as well as the spinal cord, but multiple segments. The diagnosis of NMO is confirmed with antibody testing for the NMO antibody. So with that, thanks for your attention. We went through a whole gamut of neurological conditions, and good luck on your exam.